Alrighty. Let's talk about some biostats. This will be a 6-part series, and at the end of each video we'll have a set of practice problems, so make sure you subscribe, and without further ado, let's get started. So, starting off with a quick definitions refresher. So incidence will be your number of new cases of disease over your at-risk population, whereas prevalence will be your total number of existing cases over the total population. So some really high yield facts to remember are that as treatment improves, prevalence will increase, but incidence will not change. And that's because your treatment will reduce mortality or morbidity, so your total number of existing cases will increase, but you're not going to change the number of new cases. But as your diagnostics improve, then both your incidence and prevalence will increase because both the number of new cases are going up and the number of existing cases will go up, assuming mortality remains the same. So moving on to everybody's favorite table. No, not the dinner table. What we're talking about in this slide is the contingency table, also known as the 2x2 table. And what this table is showing is on the x-axis, you'll have the actual disease status, and this will be measured by a gold standard test. And this will represent the actual disease status of a person in the population. And then on the y column, for the columns, you'll have the test results from the new test that we are interested in, that we are currently testing against the gold standard. And the way I remember this is that the new test is tall, which helps me remember that the new test will be on the y-axis. And then for each of these tests, so starting off with the gold standard, you'll see how many patients were measured as positive or negative by the gold standard test, and then how many were positive or negative by the new test that we're testing. So let's quickly talk about some high yield definitions. So first we have our true positives, and this is when a person does have the disease. So the person is positive by the gold standard, and the new test correctly says that they do. So the gold standard and the new test both concur, so it's true. The false positive is when the person does not have the disease, but the test incorrectly says that they do. So they're negative by the gold standard, but positive by the new test. True negative is when the person does not have the disease, and the test correctly says that they don't, so they both agree. And false negative is when a person does have the disease, but the test says they don't. So again, you always want to look at the gold standard first, and that will help you determine whether or not you'll be looking at a true or false positive or negative, because you always are comparing the new test against the gold standard. So you just always assume the gold standard is correct. All right. So moving on, going into what this looks like in, again, our 2x2 table, is that when you both agree positive, then you have your true positive, right? Because the person has a disease by our gold standard test, which is always right. So you always assume the gold standard is correct. And it's also positive by our new test that we're looking at. So they both agree, true positive. And then when our gold standard, it says the person is negative, but our test says that they're positive, then it's a false positive. Our test is wrong. It's like comparing against an answer key. Okay, and then when the gold standard is positive and the test is negative, then it's a false negative. And when the gold standard is negative and the test is negative, they both agree, so it's a true negative. So let's do a quick sample case. So let's say we have a 45-year-old woman presenting for routine screening. She has no significant medical history and feels well. She agrees to participate in a study evaluating a new blood test for the early detection of rare disease X. So rare disease X, a total of 1,000 participants were enrolled in the study, and 10% were confirmed to have the disease based on the gold standard testing. Among 100 participants with the disease, right, because it's 1,000 times 10%, well, let me write 1,000 times 10%, which is also equal to 0.1, is 100. So 100 participants that have the disease, 90 tested positive with the new test. So the new test got 90 out of 100 of the positive patients by the gold standard. And of the 900 participants without the disease, 90 tested positive. And 900 participants don't have the disease because it's 1,000 total participants minus 100 with the disease. So that's 900. So let's see what the examiners want from us. They want us to look at the number of true positives, false positives, true negatives, and false negatives from the study. So again, looking at the 2x2 table again, we can just fill out the 2x2 table and have the answer to the question. And I kind of broke it down to look at the most important salient points from the whole case, because there's a lot of yapping going on. So again, 1,000 participants, 10% had the disease based on the gold standard testing, which 10% of 1,000 is 100. Of those 100 with the disease, 90 tested positive with the new test, and of the 900 without the disease, 90 tested positive. So let's fill this guy out, huh? So our 2x2 table, on the y-axis, I always remember, right, test is tall. So I remember this is where our new test is, and this is where our gold standard is. So what goes in this left column here? So this would be positive, negative. So this would be our true positives here on the top left quadrant. So of our true positives, there are 90 that tested positive that also had the disease. So this would be 90 here. So this would be our true positives is 90. So that means of the people with the disease but that tested negative, that would be 100 minus 90 equals 10. So these are people who had the disease by the gold standard but tested negative. All right, very good. And then moving on, now we'll do this top right-hand spot. So these will be patients who were negative by the gold standard. So that's 900 people, but were marked as positive by the test. So that was 90. These are our false positives. And then we will have our true negatives here, which will be 900 minus 90 equals 810. So let's see how we did. 90, 90, 10, 810. So we nailed it. Very good work, everyone. Let's keep moving on. All right, moving on to sensitivity and specificity. So the definition of sensitivity will be your true positives over your true positives plus your false negatives. So if you remember where the false negatives were, on our 2x2 table, it was, so again, we have test is tall, so test is here, gold standard is here. Gee, it's not letting me write. All right, test on the y-axis, gold standard. So when we have positive and positive, then we have our true positives here. And when we have positive but negative by our test, then we have our false negatives. So this will be where our sensitivity can be found. And I want you to think of sensitivity as your ability to detect a disease if present. So you've probably been looking at this GIF or GIF or whatever you want to call it, of this security guard not doing a very good job. I wouldn't want him as my security entering a venue. So what do you think the sensitivity of this security guard is if someone is bringing something into the venue, right? So again, sensitivity is your ability to detect something if somebody brought something. So let's say somebody has a water bottle, but it's hidden in their jacket. Do you think this guy will be able to detect it? I don't think so, right? Because he's not really doing a good exam. You know, this is like a physical exam from a guy that's 2 days out of retirement, that's a hospitalist, doesn't really care. You know, he's not a med student or one of you guys watching this video that I know does a thorough physical exam every time. So this security guard would have a low sensitivity because his ability to detect a true positive, if present, is pretty low. But there will be a lot more false negatives because he's saying all these people, even if they brought in a water bottle, didn't bring in anything, which is a false negative. On the other hand, specificity will be your ability to say whether a person truly is negative. And you can think of specificity as the true negative rate. And it'll be calculated as a number of true negatives divided by the true negatives plus the false positives. So let's do a quick example. So before we get into our example, we'll look at our 2x2 table again. And like I talked about, you can calculate the sensitivity and specificity using the columns of the table. So let's do a quick sample case. So this is the same case as before. 45-year-old woman presenting for routine screening for rare disease X. So there were 1,000 participants, 10% were positive based on the gold standard. Of 100 participants with the disease, 90 tested positive with the new test, and among 900 participants without the disease, 90 tested positive. So now we want to calculate the sensitivity and specificity of this test. So we already calculated this gold standard versus test 2x2 table. So I won't make us do it all again, but essentially this slide will be demonstrating how we can use this 2x2 table to calculate the sensitivity and specificity, as I'm sure you all know. So again, let's calculate sensitivity first. So sensitivity will be our true positive rate, right? True positive rate. So I want to think of that as our true positives divided by our true positives, which is here, plus our false negatives. So that will be equal to 90 divided by 90 plus 10, which is 90%. So let's see if we got that one. 90% sensitivity was correct. So sorry for the writing, I know it's a little confusing. So let's do specificity now. So specificity, again, I want to think of as our true negative rate. So that will be our true negatives divided by our true negatives plus our false positives. And that's equal to 810 divided by 810 plus 90 equal to 810 divided by 900, which I think is also equal to, yeah, it's 9/10, so it's equal to 90 as well, 90%. So let's see what we got here. Yep, 90% specificity. Alrighty, so now we want to, since we all love mnemonics, let's talk about one that I'm sure you've already heard. So spin and snout. So what this means is, starting off with spin, a test with a high specificity can rule in a disease. And then snout means a test with a high sensitivity can rule out a disease. And you can remember that with this little Geico commercial, spinny pig guy. And he's got the snout and he's got the spinny pinwheels. So spin and snout. Again, a test with high specificity can rule in a disease, and a test with high sensitivity can rule out the disease. So clinically, you want your screening test to be sensitive, right? Because this is your true positive rate. So you don't want to miss positives. And you want your confirmatory test to be specific, because this will assess your true negative rate. So a specific test will be more likely going to call something negative. So if it is positive, that means that that means if a test does call a person positive, it's more likely to be true, essentially. It'll affect your positive predictive value, which we'll talk about in just a second. So you don't want to overcall your positives. All right, like I alluded to, let's talk about positive predictive value and negative predictive value. So positive predictive value is the likelihood that a person who tests positive is actually positive. So it's pretty simple, actually. Like, it is exactly what the name says it is, right? It's it's how good is this test at predicting if a person actually is positive. So think of it as if a test returns positive, how likely is that to be true? So for the equation, you want to look at the true positives against all positives in the test. And that's what that'll look like. So it'll be true positives over true positives plus false positives. All right, negative predictive value now is a probability that a person who tests negative does not have the disease. And this will be your true negatives against all negatives in the test. Again, that'll be your true negatives over your true negatives plus your false negatives. So going off our 2x2 contingency table, you can see that you can use the x-axis or the rows component to calculate your positive predictive value and your negative predictive value, because you'll have your true positives and then your false positives. So you'll use those two values for your positive predictive value, false negatives, true negatives here. Use those for your negative predictive value. So here's the same sample case, but this time it's asking us to calculate the positive predictive value and negative predictive value. So again, we have our 2x2 table that we filled out now. This is the third time. So starting off with positive predictive value. So again, positive predictive value is our how likely it is that a person truly is positive if they test positive. So that'll be our true positives divided by all the positives that the test said were there, which is just the true positives plus the false positives, which will give us 90 divided by 90 plus 90, which is like 50%, if my math is correct. So yep, 50% positive predictive value. On the other hand, negative predictive value will be our true negatives divided by our true negatives plus false negatives. It'll just be the number of negatives that are true over all negatives from the test. So that will be 810 plus 810 over 10 plus 810, which is, I mean, I can't do this off the top of my head, but essentially 99%. So here is a very high yield table. Please learn it. So this is our 2x2 contingency table right here that we all know and love. And using the columns component of this 2x2, you can calculate sensitivity and specificity. On the other hand, if you use the rows, you can calculate positive predictive value and negative predictive value. So super high yield to know this. Honestly, you can not know anything that I just talked about conceptually, but if you have this memorized, you can get all the questions right on the exam. But you know, I do like to understand things conceptually so I don't have to keep coming back to rememorize it. So that's why I took a little bit longer to explain things. So an easy way to distinguish between sensitivity, specificity, and positive predictive value versus negative predictive value is just think about the extremes. So for sensitivity, which is also our true positive rate, that's going to be the probability a test will be positive if the patient truly has a disease, right? You're not going to miss any positives. So for sensitivity, you should think about a ref that calls anything that's remotely close to a foul. Like you could sneeze on someone and the ref will call it a foul. So you'll have great sensitivity because you're not going to miss any fouls. The problem is you're going to call a lot of phantom fouls or fouls that aren't there, which is going to decrease your positive predictive value because you're just going to call a lot of nonsense. You're going to call a lot of non-fouls as fouls. So again, positive predictive values are true positives over our true positive plus false positives. So our true positives will be good. You know, we're going to probably get almost all the fouls that happen during the game. We're probably going to get all the true positives, but our false positives are going to go way up because things that would have otherwise been called a true negative are now being called a false positive. So that's what happens when you increase sensitivity. On the other hand, looking at this table, so we have two populations here. One is our true negative population, which is in green here, and then we have our true positive population, which is in red. And you can see that when we move from the line here in the center and we move it to the left, we end up having 100% sensitivity. So we will call all these fouls here. This will all be shaded in. When we have our cutoff line at A. The problem is, look at all this in green is people who are actually in the true negative population who end up being called positive. So these will all be false positives here. Now let's contrast that. Specificity is a probability that a test will be negative if the patient does not have the disease. So if a test has 100% specificity, you'll have a lot of false negatives, but you will not have any false positives. So you want to think about a ref that never calls fouls unless an actual assault was committed. So all the non-fouls will be correct no calls. You're not going to call them, but now you missed all the actual fouls. So you'll have increased specificity because you're calling all the correct true negatives, but because you're calling none of the fouls, you'll have a lot of false negatives. So your negative predictive value will decrease. So this is another super high yield slide, super commonly tested on every exam. So when you have increased sensitivity, your positive predictive value decreases, and that's because you're increasing the amount of false positives. But when you increase sensitivity, you obviously decrease the amount of missed positives, so you reduce the amount of false negatives. However, when you increase the specificity, then the negative predictive value decreases, and that's because you'll have a lot more false negatives, but you'll have a lot less false positives, because you're basically not really going to call anything a foul. You're like, well, I know he hit him in the face, but I'm not going to call it because I don't want to accidentally call a false positive. So let's talk about this cutoff line. So normally our cutoff line is set, assuming both populations are normal distribution. So we have population A, which is our true negative population. So all of these people within this first normal distribution are true negatives. And then B, which will be our true positive population. You can see here there's overlap, and that's what we're capturing when we move the cutoff line from left to right, or right to left. So let's say we move the cutoff line to the left. What's going to happen to our sensitivity, specificity, negative predictive value, and positive predictive value? Super high yield to know this. So we're moving our cutoff line, it was originally at 40, and now we're moved it down to 30. So all of a sudden, all of these things that are to the right of the cutoff line are now called positives. So looking at the chart, we're going to have a lot more of these negatives that are now being called positives. So we have a lot more false positives increasing. But on the flip side, we also have basically the entire population of the false positives being called positives. So our true positives increases. So what's going to happen? So when we move the cutoff to the left, then our sensitivity increases because we're going to capture more of the true positives. However, the positive predictive value will decrease. When we move the cutoff to the left, the negative predictive value also increases because you'll have a low number of false negatives. Basically, when we move the line to the left, now the only false negatives are right here. So your false negatives go way down. So your negative predictive value increases. On the flip side, your specificity will decrease and your positive predictive value will also decrease because you have a lot of false positives. And with the specificity, you have a lower threshold. So you're going to call a lot more things positive here that you wouldn't have otherwise called positive. All right, now let's have what happens when we move the cutoff line to the right. So now when you move the cutoff line to the right, all of these negatives are correctly being called negative. But now you have all of these in the positive population that are being called negative as well. So your false negatives go up quite a bit, but your true negatives are increasing, and your false positives are also decreasing. So when we move the cutoff to the right-hand side, then our sensitivity decreases because we're capturing less true positives, and our negative predictive value also decreases, right? Because if you think about it, we're moving the threshold now to the right, then we're going to have less things that we're actually calling positive, but we have very few false positives because very few of the people in the negative, true negative population are going to be called positive. And then so that means specificity will increase and positive predictive value also increases because anything called positive at this point, you probably actually are positive. The problem is you're not capturing all the positives. So here is a summary of what we just talked about. This is really high yield to know. Learn this, memorize this, whatever you got to do. Learn this table, know what happens when you move this cutoff line from left to right or right to left or sideways or vertical or diagonal. Not actually. Just know what happens when you move it left to right in terms of sensitivity, specificity, positive predictive value, negative predictive value. All right. Again, here's another topic that's super high yield. Positive predictive value and negative predictive value are affected by prevalence. And then sensitivity and specificity are intrinsic to the test. So when the prevalence of a population changes, then negative predictive value and positive predictive value are affected because these are affected by something called pre-test probability, which you can kind of assume. We're making a lot of logical leaps here and there's a lot of mathematics involved, but you can essentially assume prevalence is about the same as pretest probability for rare diseases, whereas sensitivity and specificity are a factor of the test themselves. Now, as prevalence of a condition in a population increases, then positive predictive value increases, negative predictive value decreases. So let's think about the extremes here. If 100% of a population had a disease, then any person who tested would also be positive. So positive predictive value would be 100%. In contrast, if nobody had the disease in the population, anybody you tested would test negative. So the negative predictive value, well, the positive predictive value would be 0, and the negative predictive value would be 100%. So let's do one more sample case from earlier, but this time the only thing I've changed is that the prevalence of disease X went from 10% to 50%. So let's see what happens to the positive predictive value and negative predictive value. So I went ahead and just filled out the table for you. So that's what the table looks like. So the positive predictive value went up and is now at 90%. And the negative predictive value is also at 90%, when before it was like 98% or something like that, or 99%. So that's what happens if you increase, so with increased prevalence, positive predictive value increases, negative predictive value decreases. All right, and then the ROC curve is something that's high yield as well, but essentially this just shows how well a test can tell the difference between two groups, like sick versus healthy. And the plot will be the true positive rate, which is sensitivity, versus the false positive rate, which is 1 minus specificity. And you're looking for the AUC, not AOC like the politician, but AUC, area under the curve. And the closer to 1 you get, or closer to a right angle, the better. So the more area under the curve, the better. So again, you want the closest thing to a right angle that you can get. So a curve that looks like this is better than a curve that looks like this. All right, finally we've gotten to the practice questions, long awaited. So let's say we have a 55-year-old woman that undergoes a new screening test for a very serious syndrome, strudel infatuation syndrome, SIS. This test correctly identifies 90 of 100 women who have SIS, but it incorrectly classifies 20 of 200 women without SIS as positive. And this question is asking, what is the sensitivity of this test? So our answer choices are 45%, 60%, 75%, 90%, or 95%. So let's make our good old-fashioned 2x2 table. So we have our gold standard on the x-axis, and then on the y-axis we have our test, right? Because test is tall. So this test correctly identifies 90 of 100 women who have SIS, so that means our true positive is 90. And that means we have 10 false negatives. And then it incorrectly classifies 20 of 200 women without SIS as positive. So this is 20, and then this will be 180. So we want to find the sensitivity of this test. Sensitivity, again, is our true positive rate. So that'll be true positive divided by true positive plus false negative. So that'll be 90 divided by 90 plus 10, which equals 90%. So let's see. I picked D. That is correct. And this is someone who's affected by SIS, very serious. Not so good. And some would say it's really not so good. Please share, like, and subscribe if you don't want to get SIS. All right, next is question number 2. So let's say we have a new diagnostic test that's developed to detect disease S. Among 400 people without disease S, 360 test negative. And then among 100 people with disease S, 80 test negative. What is the specificity of this test? So our good old friend, our 2x2 table again. Test is tall on the y-axis, gold standard on the x-axis. So among 400 people without disease X, 360 test negative. So that means our true negatives are 360, which means our false positives are 40 from this. And then among 100 people with the disease, 80 test positives, so that means 20 are false negatives. So what is the specificity of this test? Remember, specificity is our true negative rate. So that'll be our true negatives over our true negatives plus false positives, which will be 40, or rather, we want our true negatives, which is 360. So 360 divided by 360 plus 40, which is equal to 90%. Let's see if we are correct. And we are correct. Very good. So, question number 3. A rapid test for strudel infatuation syndrome, SIS, has a sensitivity of 80% and a specificity of 95%. If SIS prevalence changed from 10%, changed to 10% from 1%, so it went from 1% to 10% in a population, which of the following will occur? So, we're increasing prevalence, which increases the pretest probability. So A, positive predictive value increases. I think this is true. If this were a real exam, I probably would just pick this and move on. But we'll read the rest of the answers. Positive predictive value decreases. Positive predictive value stays the same. Sensitivity decreases or specificity increases. So I know that these two are intrinsic to test. So these are both automatically incorrect, D and E. Positive predictive value, no, doesn't stay the same. I actually already know positive predictive value increases, so I'm just going to save us some time and move on. And I know you all would have gotten that at home the moment you even read the question without even looking at the answers. All right, a 30-year-old man is tested for strudel infatuation syndrome with the test that has high sensitivity and moderate specificity. The prevalence of SIS is unfortunately low in his population. Nobody's watching strudel, which is sad. Which of the following is most likely true regarding the test's negative predictive value? So we have high sensitivity and moderate specificity and a low prevalence. And again, prevalence is really important to take into consideration when you're looking at negative predictive value and positive predictive value. So, A, negative predictive value is low due to low specificity. B, negative predictive value is high due to high sensitivity and low prevalence. C, negative predictive value is low due to high sensitivity. D, negative predictive value is unaffected by disease prevalence. Or E, negative predictive value equals specificity in low prevalence settings. So what are we thinking? So I would be thinking that negative predictive value should be high off the bat because their prevalence is low. Remember that, thinking back to a population that has 0%, let's say there were 0 strudel fans in the population, that means anybody you would test would be negative. So your negative predictive value would be 100% if the disease prevalence was 0. So the fact that they're telling us that prevalence is low, I would say negative predictive value is high. And there's only one answer choice that has that, so I pick B, and that is correct. All right, question number 5. A test for a rare disease known as Strudel-Hayter syndrome is positive in 50 out of 50 patients who actually have the disease. It's also positive in 950 out of 9,950 people who do not have the disease. I don't know why I didn't just put 1,000 out of 10,000 people who do not have the disease. What is a positive predictive value? So we can do this one without even testing, without even making a 2x2 table rather, because we know positive predictive value is the likelihood that a positive test means you actually will be positive. So that'll be your true positives over all positives in the population. And we know that there are 50 true positives. Oh, this is why I made it this way. Plus 950 false positives. So that means it's 50 over 1,000, which is like 5%. So it's A, 5%. So that helps us kind of understand more that in really rare conditions, even if your sensitivity is quite high, you can still have or even if your specificity and sensitivity are high, you can still have a low positive predictive value just because there are few actual positives in the test. Most positives you get will still be false positives. All right, thanks for watching, everyone, and this will be continued in part 2.